So today we have a hematology case presentation by Dr. Hanna Mariam, who is the family medicine resident at Aster MIMS Hospital, Calicut. The session will be moderated by respected Dr. P.K. Shashidharan sir, who is the senior consultant and academic head at the Department of Internal Medicine and Family Medicine at Aster MIMS Hospital, Calicut. So heartfelt welcome to you, sir, and also to Dr. Hanna Mariam and all the participants. So I think without delay, we can begin the session. Over to Dr. Hanna.
Thank you.
And Dr.
Well, one word, I actually did not find out which case she is presenting. Even that mention of hematology case is not needed when we discuss a case. So I would, because I would like to discuss it as an undifferentiated problem. Since I do not know the diagnosis, I will have the same approach. Let Dr. Hanna present the case. We will approach it like that. Thank you.
Okay, sir. Can I start, sir?
Sir, please.
I am Hanna Mariam, DNB resident, family medicine, Aster MIMS Calicut, presenting the history of 53-year-old gentleman hailing from Vadagara, who is a painting worker. He presented with complaints of rashes all over the body for 2 days, bleeding from gums for 1 day, dark-colored urine for 1 day. He was apparently normal 2 days back, and his symptoms started as tiredness, which he noticed during his daily activities, and hence he preferred to stay in bed. And his son noticed reddish rashes over his upper back, which were initially confined to his upper back, and later they noticed it to involve all over the body within 2 days. These rashes were painless, non-pruritic, and there was no history of trauma. Next day in the morning, while he was brushing, he noticed bleeding from gums, which stopped only after rinsing multiple times within 5 minutes. He also noticed reddish spots over his tongue and lips. They consulted nearby hospital, and while in hospital, he had one episode of dark-colored urine, and there was no history of facial puffiness or reduced urine output. No history of fever, myalgia, conjunctival congestion, headache or neck stiffness. No history of joint pain, blackish stools, hemoptysis or abdominal pain. No history of any analgesic intake or recent vaccination. No history of loss of appetite or loss of weight. No history of recurrent infections. No history of shortness of breath.
Okay, this is the presenting complex. I hope you can hear me clearly.
Okay. Oh, sir.
Okay, you can hear me.
Sir.
Okay, so let us see. Let us see what all are the problems based on this history and the presenting complaints. 53
sir, pictures.
Pictures we will discuss after the history. Okay.
Okay.
Let us see what all are the is based on that history. 53-year-old male. He had rashes over the body with bleeding gums and dark urine. Was it dark urine or hematuria?
Sir, dark-colored, reddish-colored, dark-colored urine, hematuria.
Now, if it is bright red, definitely it has to be blood. If it is altered,
bright red,
then you can say it is hematuria, because it will be different when you say it is bright red urine, which means definitely hematuria. If it is something else, it can be deep jaundice or hemoglobinuria. Any of this is possible. So if the urine is genuinely bright red, it is definitely hematuria. Then the interpretation will be different. Then the patient had rashes and the distribution of rashes. Tell what? Where it is distributed in a symmetrical manner or asymmetrical manner. Is it more in the lower limbs or extremities? Asymmetrical. It is not
more in the lower limbs.
More in the lower limb, but asymmetric. And it is there on trunk as well. Because why is it important?
Yes, sir.
Why is it important to know the distribution?
Vasculitic lesions.
Big rashes. These kind of sudden onset, multiple rashes and all over the body. If they have a distribution in predominantly in the extremities, that too more in the lower limbs and the less so in the upper limb extremities, it is definitely a vasculitis. So that is why the distribution is important. In that case also you can get a hematuria. So hematuria is possible even in a vasculitic disorder. So the distribution is not in favor of a vasculitis. And then there is bleeding gum also. Is that clear? There is bleeding gum. And said,
Yes.
he did not have any fever. He did not have any other symptoms other than this symptom. Is it true?
Yes, sir.
There is no fever, myalgia, headache, or no, only these bleeding symptoms. So with that,
Yes, sir.
and with the picture you had shown, what is it? What will you consider with the picture?
Mucosal bleeding.
It is what? Is it a bleeding disorder or a clotting disorder?
Bleeding disorder, sir.
Yes, it is a
Bleeding
bleeding.
disorder, sir.
It is a bleeding disorder, obviously, and never a clotting disorder, because clotting disorder will not come with these kind of superficial bleeds. And the next, which are the bleeding disorders you know? Which are
Platelet disorders, thrombocytopenia.
severe you have to consider severe thrombocytopenia here. Other bleeding disorders are less likely because of the dramatic nature and the severe the rashes or the what you saw in the mouth is called a wet purpura or bloods, which indicates platelet count less than 10,000. Then only you will get this kind of bleeding in the oral cavity. Definitely, it is a severe thrombocytopenia, and it is severe thrombocytopenia, severe enough to produce this much bleeding can occur when the absolute platelet count is very low, or when there is a rapid drop from normal to low levels like 20,000. Suppose some 3-4 lakhs to suddenly it becomes 20,000 also you may get it. Otherwise, usually in a chronic ITP like situation, if you find a lesion like this, it is usually platelet count less than 10,000. Anyway, there is severe thrombocytopenia. That is there. And then what is the possible cause for that severe thrombocytopenia from the history?
It's an acute onset.
Uh,
No loss of weight, loss of appetite.
no
So
constitutional
can be
symptom. There is no constitutional symptoms.
constitute
Absence of constitutional symptoms in a patient with severe thrombocytopenia favors what?
immune thrombocytopenia.
Immune thrombocytopenia. That's very good. Immune thrombocytopenia, when you consider, what are the other close differential diagnoses?
Hematological malignancies.
No, hematological malignancies, they usually have fatigue, tiredness, progressive are also along with that. Constitutional symptoms are usually present in hematological malignancies with the bone marrow infiltration, like low-grade fever, tiredness, fatigue, and obviously you will find the patient having severe pallor also. But still, you are right. You have to consider that possibility. Provided what? What will you look for if you to rule out a hematological malignancy by physical examination?
Pallor.
Severe,
Examination pallor.
severe
Sternal angle tenderness.
sternal tenderness, organomegaly.
Organomegaly.
Organomegaly. If you find splenomegaly, lymphadenopathy, because if you find lymphadenopathy or splenomegaly, you can be confident in saying that it is not ITP. It has to be something else. So you will look for that. Suppose you do not find anything except this bleeding and apparently normal looking person, clinically itself you can say it is a chronic ITP like situation. Or if it is a pediatric patient, you could have thought of what?
Acute ITP.
In an adult, you should
Acute.
acute ITP. In an adult, actually, you should not diagnose acute ITP. Acute severe thrombocytopenia, you can diagnose. Acute ITP is not usually seen in adults. So you will think of a chronic ITP if rest of the examination and hemogram is normal. That is how you think at this point. And okay, let us see the rest of it.
Okay.
Any questions regarding people? Anybody has got any questions to ask at this point? If not, we'll ask in the end. Okay. Please go ahead. Hello, can you hear me? Hello.
Yes, sir. Continue.
Continue though. Please continue.
Pictures showing lesions, rashes. Sir.
Your voice is
Hello.
Hello. We can see. Please go ahead.
Sir, these are
Voice is getting
pictures of rashes, similar rashes. Okay, sir. Past history, he had history of atopic tendencies, and he had history of fever with similar rashes 7 years back. And at that time, he was diagnosed to have viral fever. And he had history of type 2 diabetes mellitus since 5 years, and he is on regular medications. He had history of weakness of left upper limb and lower limbs in 2022, which recovered spontaneously within 2 hours. And imaging was done at that time and was told normal. And he is on regular medication since then.
What are the possibilities with this history? He had 7 years back. He had a fever with a similar kind of rash, and it was treated as a viral fever. What
Yes.
are the possibilities?
At that time, he should have been having dengue fever or.
Okay, that is one possibility. It could, if it was a short febrile illness, you can think of dengue fever. If not, what is the possibility? With this present history, you can think of chronic ITP because any viral fever can result in a rapid drop in platelet count in a patient with a chronic ITP. So, because chronic ITPs remain asymptomatic till they develop such dramatic drop in platelet count. So, the first episode can be after a viral fever. But viral fever related thrombocytopenia, they usually recover fast after recovery from the viral illness. So if the symptoms are suggestive of fever, myalgia, conjunctival congestion, retroorbital pain, and an epidemiological setting is supportive, you can go into that history to find out whether it was a dengue fever or not. No, not leptospira. Dengue fever also has similar picture. It is conjunctival congestion can occur in dengue fever. Myalgia, pure myalgia, first you think of dengue fever only. So it could have been a dengue fever itself and complete recovery, or a viral fever, any viral fever, including dengue fever, unmasking a chronic ITP with a severe thrombocytopenia. That possibility you have to entertain at this point. And then he had a TIA 2 years ago, which recovered, and he was on aspirin.
Yes, sir.
Was he still on aspirin when he developed these bleeds?
Yes, sir.
So that means the aspirin also would have contributed to the bleeding tendency. That's how you look at it. Okay.
Okay, sir. Personal history, sleep and appetite was normal. Bowel and bladder habits regular. He does not smoke or consume alcohol. Diet history, his diet was deficient in vegetables and fruits, and he does not consume adequate protein. There was inadequate water intake. Family history, no history of similar illness in the family.
I'll ask one point which I will forget otherwise. When a patient like this has decreased intake of vegetables and fruits and does not take adequate protein, which protein you mentioned only, which kind of protein, what kind of protein you had in mind?
Animal
protein, does he take or not?
He consumes less amount of meat.
It is not the quantity, it is a frequency that is more important.
Frequently he takes.
How frequently he used to take?
Once a week.
Once a week. Okay, even that is less frequent. And he does not take adequate vegetables and fruits. How that particular issue can affect his platelet count?
Ineffective erythropoiesis, beetle deficiency,
Not erythropoiesis.
ineffective bone marrow functioning.
You can get thrombocytopenia due to these deficiencies also, either beetle, folic acid, or both. Both deficiencies are possible in this patient. So that will also contribute to the low platelet count. Okay. Next.
Family history, no history of similar illness in the family, no history of any bleeding tendencies in family.
If you had got
So,
a bleeding tendency in the family, how do you correlate? Which bleeding?
Usually von Willebrand disease.
What kind of inheritance you get in von Willebrand disease? What history will help you that it could be a von Willebrand disease?
Both the clotting and
No. What history? Clotting time will be useful in diagnosing.
sir, both the large.
Somebody said autosomal dominant. This autosomal dominant inheritance. So that means if you get other members of both gender having similar history, you should think of an autosomal dominant inheritance, and von Willebrand disease becomes a possibility. That is one thing. But von Willebrand disease will not come with bleeding from multiple sites. They usually have bleeding after some kind of trauma from a single site. This kind of extensive multiple site bleeding is usually not von Willebrand disease. There is another condition which is inherited, which can mimic ITP. What is that? Anybody? Don't forget Bernard-Scholier syndrome, which behaves like chronic ITP. So if there is a family history, then you have to think of one of these congenital bleeding disorders. Anyway, you will not think of clotting disorders. Is von Willebrand disease a clotting disorder or a bleeding disorder?
Sir, both factor VIII and platelet function is affected.
It is simply a bleeding disorder. It is not a clotting disorder. Theoretically, only it is a clotting disorder because you will not get coagulation abnormalities when the factor level is around 40%. Even with the 5%, you don't get it. So the problems are all due to the platelet dysfunction. Coagulation abnormality, that is only in testing. Sometimes you may get some APTT prolongation. That is the only thing. Otherwise, clinically, they will not behave like a coagulation disorder. You know the pattern of bleeding in coagulation disorders. How do they bleed in coagulation disorders?
Hemarthrosis.
Deep bleeding, deep hematomas. So that kind of history you will not get in most of the common types of von Willebrand disease. Rarely you may have some variants with very low coagulation factors, then you might get it. Otherwise, it is not common. Most of them have adequate factor VIII, so they won't come with hemophilia-like presentation. Okay.
Next. Socioeconomic status. He lives in a well-ventilated room with adequate space, good sanitation facility, not enrolled in health insurance. His nearest health facility is around 1 kilometer distance and expenses met by him and his son. Summary. 53-year-old gentleman, known to have type 2 diabetes mellitus and atopic tendency, history of TIA on regular medication, whose diet is grossly deficient in proteins, fruits, and vegetables, now presented with multiple petechiae all over the body, associated with spontaneous bleeding from gums and dark-colored urine.
At this stage, you can suggest a clinical probability, clinical diagnosis.
Can be acute bleeding disorder.
Severe thrombocytopenia. You can definitely say severe thrombocytopenia, possibly chronic ITP, but you will look for evidences of bone marrow infiltrating disorders like leukemias. Okay.
Okay. Differential diagnosis.
Acquired is all right. Hematological malignancies means bone marrow infiltrating disorders. B12 deficiency cannot present with bleeding. B12 deficiency alone will not have platelet count which is very low to produce wet purpura.
Okay,
They can have platelet count around say 40,000 or more, not less than that. If you get a severe thrombocytopenia, B12 deficiency can be there in the background, but B12 deficiency alone cannot produce such severe thrombocytopenia. Autoimmune disorders, you are right, because they can behave like ITPs itself is an autoimmune disorder. In the background, patient could be having an autoimmune disorder. Agreed, aplastic anemia also can present with sometimes with severe thrombocytopenia. That is right. But B12 deficiency is an associated problem, not a differential diagnosis. Okay.
Okay, sir. Coming to general examination, he was conscious, oriented, cooperative, and he was seen comfortably lying in the bed. His height was 162 centimeter, weight was 61.5 kilogram, BMI was 23.4 kilogram per meter square. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There was no sternal angle tenderness. On local examination, he had multiple petechiae and purpura all over the body, predominantly over trunk and largest of size measuring 10 millimeters, which was non-blanching, non-palpable. Hair nails were normal, no thyroid swelling or varicose veins. Clinically, he was euthyroid, no features of chronic liver disease.
So what features did you look for?
Chronic liver disease.
What features did you look for?
Clubbing, palmar erythema, spider navy, gynecomastia.
Any other? These are far advanced chronic liver disease. Chronic liver disease should be picked up before they develop such frank signs of chronic liver disease. So what are the subtle signs that you will look for in a patient? Why chronic liver disease is important in this patient?
Liver disease, vitamin K deficiency.
Anybody? Why liver disease? Why liver disease is important in this patient? We must know that chronic liver disease can present like ITP. Chronic liver disease can present like ITP. They can have severe thrombocytopenia also. They can have ITP-like presentation. That is why the chronic liver disease you have to look for. So even subtle signs of chronic liver disease is important because it is not due to defective synthesis of clotting factors. Chronic liver disease has ITP-like thrombocytopenia due to several mechanisms. One is defective clotting mechanism will not manifest till the liver disease far advanced. But thrombocytopenia is very common. They can behave like ITP also, especially if they have chronic active hepatitis. Thrombopoietin issue is not the primary issue, primarily due to some autoimmune mechanisms coming up in the background of chronic active hepatitis, plus hypersplenism, folic acid. Multiple factors are there in a patient with chronic liver disease to produce thrombocytopenia. So you should look for chronic liver disease in anyone who clinically has a ITP-like presentation. And the subtle signs you will look for are what? Always look for white nails.
White nails.
It is an advanced liver disease sign. If it is there, it is all right. But you will not wait till clubbing and all comes. One is white nails. Then what? Skin changes. Skin changes of chronic liver disease you must get familiar with. You can predict the presence of chronic liver disease if you are familiar with it. They have a dry lustreless skin, but there are other causes also. Look for skin changes and nail changes and a phlegm hepatomegaly. If there is a phlegm hepatomegaly, especially this patient with a BMI of 23, he is overweight, he has diabetes, he is a potential candidate for fatty liver disease. So liver disease may be a cause for thrombocytopenia, whatever may be the mechanism. So you have to look for liver disease, not just saying that no features of chronic liver disease is not enough. Subtle features Okay, that is a correct step. Next, thank you.
Okay, sir. Vitals, he was a febrile, pulse rate was 100 per minute, regular rhythm, normal volume and character. All peripheral pulses were palpable and equal bilaterally. No radioradial or radiofemoral delay. No vessel wall thickening. Blood pressure was 110/70 millimeters of mercury in right arm, supine position. Respiratory rate was 16 per minute, regular, abdominal thoracic. Systemic examination, gastrointestinal system on inspection, good oral hygiene. Petechiae was present over posterior part of
Again,
heart valve.
family doctors, you must, that point is very important, good oral hygiene. Because even a patient with thrombocytopenia may be bleeding from the gums due to poor orodental hygiene also. That is one thing that you have to address to prevent bleeding from gums in a patient with ITP. So good oral hygiene, and if the gum is otherwise normal, there is no local cause for the bleeding. Okay.
Petechiae was present over posterior part of heart, palate, and lips. Purpura over tongue. Shape of abdomen was normal. There was multiple petechiae over abdomen also.
The purpuric,
All quadrants move.
that what was seen is not purpura, not the usual type of purpura. You have seen one large,
Purpura.
that is a purpura.
Mm.
Otherwise, petechial spots only are usually are called purpura. Okay.
Shape of abdomen normal, multiple petechiae over abdomen. All quadrants moves equally with respiration. Umbilicus was central and inverted. There was no dilated veins or surgical scars. Palpation, there was no tenderness. There was no hepatomegaly or splenomegaly. No renagal tenderness. Percussion, all quadrants moves equally. All quadrants were resonant. Liver dullness was felt in fifth right intercostal space in midclavicular line. Drop space was resonant. Auscultation, there was normal bowel sounds heard, no bruit heard. Cardiovascular system examination, JVP was not elevated, no visible pulsations. Apex beat felt in the left intercostal space, 1 centimeter medial to midclavicular line. First and second heart sound heard normally, no murmur or adventitious sounds. Respiratory system, trachea was central, normal vesicular bed sounds heard over both sides, no added sounds. Nervous system examination, higher mental function was normal, cranial nerves were normal, motor system examination was normal, sensory system normal, no signs of incontinence or signs of mental irritation, skull and spine was normal. Provisional diagnosis.
Acquired bleeding disorder, probable what ITP? Acute ITP,
Immune thrombosis.
acute ITP or
Chronic ITP. Chronic ITP.
What to say chronic ITP? Just because it is an adult. Second, you already have got a history of previous episode. And even at this stage, hematological malignancies, because there was not much of pallor. Was it there? Did you have pallor?
No, sir. No pallor, sir.
Not much of pallor. That means if this patient had pallor, organomegaly, sternal tenderness, definitely, or constitutional symptoms at least, you could have considered hematological malignancy. At this point, clinically, it is not a hematological malignancy, it is a chronic ITP. Now, anyway, now you can at this stage roll out after a hemogram. What findings in the hemogram will support a hematological malignancy? Like this.
Lymphocytes, more lymphocytes.
You find in the differential count, if you find lymphocyte predominance, you have to suspect a hematological malignancy. Hope others know why it is so. Because the blasts are counted as lymphocytes in the automated analyzer. So if you find say the total count comes low, even low total count is suggestive. If you find leukopenia, if you find lymphocyte predominance, you have to suspect a hematological malignancy. Straight away, you have to go ahead with the bone marrow examination. So let us see the hemogram.
Yes. Coming to investigations, complete blood count, hemoglobin was 12.1, total count 7.7, and platelet count was 0. Differential counts, neutrophil was 55, lymphocyte was 30.
So
Manually.
that is against a hematological malignancy because
Malignancy.
hemoglobin is preserved, daughter count is normal, differential count is normal. At this stage, there is nothing to suggest a hematological malignancy. Now, what will you do? Next step.
Peripheral smear.
Yeah. What is objective?
Platelet count.
Platelet count. It's not platelet count.
Size.
It is not the platelet count that we are now looking for. Patient has a very low platelet count. That is obvious from the history itself. I told you that.
Anemia.
For not for anemia. You are looking
Schistocytes.
for rule out blast. Very good. Somebody said blast. You are looking for abnormal cells. Peripheral smear is to look for abnormal cells, blasts in the peripheral blood. So peripheral smear is important in this patient because it is a first episode. Apparently first episode.
Next, peripheral smear.
Yeah.
Showed normocytic normochromic blood picture with a severe thrombocytopenia.
Now you can confidently say it is a chronic ITP. Next question is, do we need a bone marrow examination in this patient? What will be your answer?
Not needed.
Not needed. Actually, it is needed. You can straight away go ahead with treatment. In case by chance there is some lack of response, only you need to consider. But theoretically, you are right. Technically, you are right. Sometimes in a court of law, also you might say, the people might say, bone marrow should have been done. But actually, for practical purposes, when you find at least there is an excuse not to do a bone marrow, you can go ahead with the treatment. In this patient, you can say it is an chronic ITP. But after diagnosing chronic ITP, what is the next approach?
Management.
Before management, anything else need to be done? Anybody? Management comes in the management part at least. Anything else? Any other point to be looked for? Or will you straight away say it is only chronic ITP and you won't do any more evaluation? Or what else will you look for? No, bleeding and clotting time has no meaning. Patient is already bleeding. Viral markers is correct because this can be a manifestation of chronic retroviral infection and SLE. So you may have to look for a not LDH levels. You have to look for a ANA profile, and retroviral screening is important, especially if you get a high risk behavior. But you may not get more often. But these two are important: retroviral screening, viral markers. All viral markers are important, but most importantly, hepatitis, HIV virus, and SLE, autoimmune disorders. It can be a manifestation of SLE. So that is why ANA profile is important. Bone marrow we can actually skip. Okay.
ANA profile. ANA was negative, sir.
Okay. ANA profile was not done.
Profile was not done.
Okay. Next, what you have done? You have shown some other investigation.
Sir, URE.
Hematuria.
Hematuria.
Or albuminuria.
Hematuria and
What
albuminuria.
about RBCs? RBCs are there, no? So
Yes, 250.
Albumin in urine?
Yes, albumin 4+.
Why is it so?
Albumin is blood is in the urine, so albumin can be
to the bladder, urinary tract. That is due to the hematuria.
Yes, sir.
Blood is coming into the bladder, and you will have albumin in it. It's due to the blood only. Then, but if you find albuminuria in this patient without RBCs, what other possibility you will think of?
He's diabetic.
No. Diabetic nephropathy is less likely. You have to think of an autoimmune disorder. Okay, bone marrow was done.
Yes, sir.
Actually, bone marrow can be avoided if you are confident. But when you are not confident, you can do the bone marrow before starting treatment. Okay.
Diagnosis.
You have to say chronic ITP.
Chronic immune thrombocytopenic purpura and the underlying type 2 diabetes mellitus, vitamin B12 and folate deficiency.
There is one more condition other than HIV and SLE. When you get a patient like this, what is that? You have to ask for a retroviral screening if there is a risk factor and ANA profile. And one more thing you have to consider is what? Suppose this is the first episode of bleeding. First episode of severe thrombocytopenia. Do not forget drug-induced thrombocytopenia. Look for all the drugs the patient was receiving. What all were the drugs the patient was getting at this point?
Aspirin was getting.
That aspirin will not produce severe thrombocytopenia.
Thrombocytopenia.
Rarely any drug can produce. Rarely any drug.
Linezolid, sulfonamides.
You may get severe thrombocytopenia due to any drug. Even ranitidine is sometimes known to produce. So any drug, if you suspect, you have to withdraw that. That's one particular point you have to keep in mind. If a patient is getting severe thrombocytopenia while on treatment with some drugs, always consider drug-induced thrombocytopenia also before you think of other causes. Okay, next one. Okay.
Management.
Okay, even Septran, Cotramaxol also, all can produce. Any management?
Here the patient is having platelets 0.
So what will you do?
Severe thrombocytopenia. So we should start on glucocorticoids.
Will you give PRP?
No, sir.
No, that is the most important point. Never give PRP in a patient with severe thrombocytopenia due to an immune thrombocytopenia. But that is not the case if it is a leukemia. If it's a pulmonary infiltrating disorder with this kind of bleeding, you have to give platelet transfusion. But if it is an immune thrombocytopenia, you will not give PRP as a treatment of choice. Instead, you will give steroid. In what form?
IV or dexamethasone. IV.
IV dexamethasone. If you think platelet count is very low, you can go for 8 milligram 8 hourly. Or because of diabetes, you must be a little bit careful. So you can go for 1 cc or 4 milligram 8 hourly to begin with. But do not forget to give folic acid and B12 in this patient. When you give steroid, the bone marrow cannot function unless you provide other things which are needed for platelet regeneration. Always give B12 injection and folic acid. You don't have to worry about hematoma while giving B12 injection because muscle hematoma will not occur with a very low platelet count. You only have to apply some pressure after injection. Hematoma will not occur. But if it's a bleed clotting disorder, don't give an IM injection. Here actually, you can even give an IM injection, but there are intravenous preparations of B12. So give B12 injection. Desperately, you can even give IM, but apply pressure after for at least 5 minutes after giving it, so that hematoma will not occur. So always you need to give B12 and folic acid to this patient. It's not enough that you give steroid alone. Then what?
Ecosprin should be stopped.
It has to be stopped. Very good. That ecosprin has to be stopped. Then?
And diabetes management.
What will you give for diabetes management?
Diet modification, weight loss.
Patient actually he is an overweight person. Better than giving loads of insulin, you can restrict carbohydrate. Restrict carbohydrate. Fill that space with high fiber vegetables, but do not forget to add some fruits and a complete protein. That patient is not a vegetarian, no?
No, sir.
No. Then you can use egg, curd, or if the patient feels like taking, you can even, but it's better not to give because his stomach may be very prone for bleeding. So it is good to give stomach-friendly food only. That means vegetables, not very spicy, vegetables, fruits, and some complete protein like egg or curd, or you can add dal. But when you add dal, you have to combine it always with cereals. That might be adversely affecting the blood sugar. So anyway, you have to restrict the carbohydrate at least, or you can totally withhold the carbohydrate if you are going for a complete protein like a curd or egg, and giving adequate vegetables and some fruits. That is important because your stomach is likely to bleed very fast because of the B12 deficiency and severe thrombocytopenia. So you have to protect the stomach, but don't give ranitidine here. This is a situation where you may have to give pantoprazole IV as one dose. After that, you manage it like any other patient. Or you can give liquid antacid also to prevent erosive gastritis. Anything else?
Bed rest, sir.
Bed rest is needed. You should not be exerting. He should not be exerting at this point till the platelet count recovers. Anything else? Diabetes management, if you otherwise, I'm not elaborating on the diabetes management part. So you have to manage it appropriately. The blood sugar should not go to dangerous levels because anyway you have to give steroid. So steroid use has to be careful. You have to use steroid, but you have to take care of the carbohydrate restriction. But if necessary, you may use insulin. But insulin is not going to work very well in this patient. Why? Why insulin may not work very well? It's a type 2 diabetes. There is already insulin resistance. So insulin is not the primary treatment in this patient, but sometimes you may be forced to use it when you want to bring down the blood sugar values, because very high sugars can produce problems like there may be osmotic diuresis and the patient may become symptomatic. So you need to control sugar only for that reason. And steroid, you have to continue till the platelet count improves. That means at least above 30,000. Above 20,000 is also good, but you can say up to 30,000. Don't wait for normalization of platelet count. 30,000 and above, you can be confident, and adequate hydration is important. Because of the hematuria, you don't have to manage. It will settle down. Hematuria as such, you don't have to manage. You never give any treatment like epsilon aminocaproic acid or those kind of drugs should not be given in hematuria. They will have problems. So you can give only steroid, B12, folic acid, and adequate hydration, because the patient who bleeds from the urinary tract usually has another problem like renal calculus. It's not genuinely due to the thrombocytopenia the patient is bleeding from the urinary tract. Most often they're bleeding due to the renal stones. Uric acid you can examine. Was it examined?
Oh,
Uric acid?
Uric acid was normal, sir.
Normal. But even if it is normal, you have to consider renal calculi as a trigger for hematuria in a patient with severe thrombocytopenia or urinary tract infection. One of them is considered. Otherwise, don't think it is entirely due to the thrombocytopenia. So you don't have to give any specific treatment for the hematuria. How can we prevent further episodes? Keeping the platelet count in the desirable range. What is desirable range?
More than 30,000.
More than 20,000 is enough. There are patients who remain asymptomatic even with 18,000 throughout life. So for each patient, the desirable level is different. And some patients, on an average, you can say around about 20,000 or 30,000, not more than that. Never treat the platelet count in a patient with ITP. It's not, you are not treating platelet count, you are treating symptoms only. An asymptomatic patient tolerating thrombocytopenia, even 20,000, you should not be in a hurry to increase the platelet count. Pregnancy also, you should not be in a hurry to increase the platelet count. But if you find an autoimmune disorder, you may have to give immunosuppressants. That is why the ANA profile is important. If ANA profile comes positive or ANA screening is positive, and you have to start on azathioprine. Azathioprine, but you have to be careful. What is the liver enzymes here?
Normal, sir.
If the liver enzymes are normal, azathioprine is the best drug if it is an autoimmune disorder. Then you can continue azathioprine to stabilize the platelet count and continue throughout pregnancy. Or sometimes nearing pregnancy, you can use low dose steroid to improve the platelet count nearing termination of pregnancy. Nearing delivery, you may use steroid temporarily to increase the platelet count. Never give PRP. Anything else? Any other question? Any other questions, points, or comments, clarifications? If patient is planning for any major surgeries, you again you will raise the platelet count by appropriate treatment before surgery, planning surgery. Any surgery can be done if the platelet count is above 80,000. But sometimes you can do surgeries even with a platelet count of 50,000. But lumbar puncture, you should avoid when the platelet count is less than 50,000. It should be done only above 80,000. So intracranial surgeries, if the patient needs by chance, you may have to desperately use PRP during surgery, because PRP is actually adding oil to fire in a patient with thrombocyte ITP. That's why you don't want to give it. But if in a CNS bleed, or when the patient has a life-threatening bleed and you have no time to wait, you may have to desperately give PRP temporarily to tide over the crisis, but anticipate further drop in platelet count once the patient recovers. So sometimes, very rarely, platelet transfusion is resorted to in intracranial bleeds or surgery in the intracranial compartment or spinal cord region. So that is only indication of PRP, otherwise in this patient. Anything else? Any other question? I didn't see any question. Any other? Okay, there are some questions there. How can we, special situations? Platelet stimulating factors can be used, but they do not give lasting benefit in thrombocytopenia. But you can use, there are several drugs. You can use thrombopoietin receptor agonist or romiplastin. You can use those drugs, but they do not maintain the platelet count permanently by use of that. It's better to accept the low platelet count and plan to maintain the patient on the low platelet count, like 20,000 or above 20,000, and keep the patient like that. And only when you need a higher platelet count, you can use these platelet stimulating factors. And IVIG only when you have, when you suppose this patient has an intracranial bleed, you can use IVIG and methylprednisolone. When you want to raise the platelet count immediately, you may use IVIG and methylprednisolone. Otherwise, you can wait. This patient is otherwise became walking, isn't it? IVIG should not be used in every patient just like that. Only when you want to raise the platelet count rapidly, because it will not have a lasting effect, temporary effect only. In acute ITP, there is no role for IVIG. You just remove the cause, give steroid, patient will improve. Acute ITP occurs in children. Anything else?
Any other doubts?
Any other point to be discussed? Hello?
Right. There is no further queries, sir.
Okay. In that case, we can wind up now.
Sir, any other questions, sir?
There was somebody has asked something.
Yes, sir.
There is one question I saw somewhere. What is that? If patient had CVA or MI, don't worry about because low platelet count will act as an antiplatelet medication. Don't worry about the aspirin. Stop it. This patient has a ischemic event. The low platelet count itself is enough to work as an antiplatelet effect. So you don't have to give it. Never give antiplatelets in patients with a low platelet count. We had patients with severe bleeding when the low platelet count was not detected properly, and patient would have come with dangerous bleeding. And even double platelets after an angioplasty because they forgot to detect the platelet count, thrombocytopenia. They overlooked the thrombocytopenia, which was moderate. Never give antiplatelets in patients with a platelet count less than 1 lakh. Anything else? Aspirin
One more
should
question.
not be given. Aspirin should not be given. There's no question of holding it. Any other question?
Sir, in patients with chronic ITP or so what about this antiplatelets in patients with below 50,000? I mean, routinely, if their platelet count is below 50,000, but they are known CAT and CVA patients, do we continue on clopidogrel or aspirin?
No, you should not give it when the platelet count is less than 80,000. Even less than 1 lakh, be careful about using antiplatelet medications, even if they have CVA or ischemic heart disease. Because that
Even with the current infarct and all recent stroke, also we can't give. Can't
recent
continue.
stroke also, antiplatelet effect, you have to treat other causes, like there may be other reasons. Most of these CVAs occur due to endothelial damage resulting from hyperhomocysteinemias or vasculitic disorders, and you may focus on other aspects rather than giving antiplatelet medications. But heparin, if you think if it is a thrombotic stroke, heparin can be given. Low dose heparin can be given.
Okay, sir. Thank
But
you.
antiplatelets, be careful when the platelet count is less than 1 lakh. But in desperate situations, if the situation demands up to 50,000, you may try it, but be careful.
So we are okay with the Novax in such cases?
Which one?
The novel anticoagulants.
No, novel anticoagulants. That depends.
Rivaroxaban or
Okay. That actually the choice of novel anticoagulants depends on whether the patient has a liver disease or not. If the patient has a liver disease, do not go for a warfarin antagonist, a vitamin K antagonist, warfarin group of drug, because already protein CS is deficient, and if you give warfarin, you may add a thrombotic tendency on top of already existing problem. So these are chosen when you think that there is a possible liver disease. That is a situation where you go for the novel anticoagulants. Otherwise, warfarin is enough.
Thank you, sir.
Any other point? If the patient has a hemorrhagic stroke, you have to give PRP. That is just to stop further bleeding into to prevent enlargement of the hematoma. Suppose it is a hemorrhagic stroke, even if it is a chronic ITP or acute ITP, give PRP to enlargement of the clot, that bleeding hematoma, because that is going to kill the patient. So you want to buy some time. That's one indication for a PRP. Any other point? But whenever you give PRP, anticipate its long-term effects, and you may have further rapid dropping or refractory ITP after giving PRPs. So you have to be careful.
Any other queries? Sir, I think there is no more doubts.
Thank you.
Sir,
Thank you.
Sir, Myself, Dr. Sujitra, PG Coordinator, Spice Road Kerala Chapter. As we come to the end of this session, it's my privilege to express a great heartfelt gratitude on behalf of Spice Road Kerala Chapter. First and foremost, I would like to thank Dr. P.K. Shashidharan, sir. It was such a thought-provoking discussion, sir, and we are so glad that we get such an eminent faculty for this session. And to Dr. Hanna Mariam, it was such a nice case presentation and such a wonderful case, Hanna. Thank you for this beautiful session. And now I thank all the participants for this session, which make the session such a nice one. We were able to maintain a participation of more than 60 delegates throughout the session. And thank you each and every one of you for participating in today's session. Once again, thank you, Shashidharan sir, on behalf of Spice Road Kerala chapter.
Thank you all. Wish you all the best.
Thank you.
Thank you, sir.